Anyway, and then after my training, I went to Vegas, where I've lived for the past 26 years. Speaking of PGAs, one of the reasons I haven't been back in a long time is because now I'm currently a visiting professor at the Department of Medicine section of Hematology and Oncology. So I train fellows in hematology and oncology because here in the Philippines, hematology and oncology are separate specialties. In the US, they're combined. So I train fellows in hematology and oncology. As a matter of fact, in 2 days, I will be there the whole day. And I do it for free. The reason being that in all my years of coming back to the Philippines, invariably I get consulted about cases, and I see a lot of things that I kind of don't agree with. So it's kind of like the old proverb where you say, if you want to feed people, you can either give them food or you can train people to become farmers, and you multiply the providers. So that's what I thought about doing. So I felt if I train good doctors here while they're young and they stay in the Philippines, then maybe the care will be improved. And so it's something I enjoy a lot because I call them kids. My fellows at PGH are extremely smart doctors. And they also yearn to learn so much. It's so rewarding seeing these young doctors learn and go out to the community, basically do the right thing. All right. So with that as an introduction, hematology and oncology are probably the two most active field in all of medicine. Something always happens in this field, literally every single day. So right before I came in here, I was checking my email because I get emails from our parent organization, ASCO, American Society of Clinical Oncology, and ASH, American Society of Hematology, about updates. And there was a very interesting update today about triple-negative breast cancer, and I'm going to talk about triple-negative breast cancer. I'm going to talk about that in a while. So a lot has happened since I was last here about 3 years ago. And it has to do with personalizing the diagnosis and treatment of tumors. So when I was a fellow, all we had available were chemotherapy drugs, right? And so I remember writing an article for Carewell in 2017, and I called it the Big C, the Big Cure. People say Big C cancer. No, that's not what's going to happen now. The Big C to me is like the Big Cure. And what's happened over the decades is that we basically had a better understanding of what happens in cancer. That was the key. So give you a very simple example. So there's a condition called CML, chronic myelogenous leukemia. All right? So we have known since the 70s that the way you diagnose a chronic myeloid leukemia is a condition where your white blood cell count goes way up. Normally it's 5 to 10,000. CML patients will have white counts of like 100,000. All right? But it's a chronic type of leukemia, meaning to say you can actually live with that disease, but eventually, you will die without treatment. So it's chronic, insidious, as opposed to the acute leukemia, which we all think about when we hear that word. But you will. The course is very malignant. It's aggressive. Without treatment, you die like within a month. Okay. Anyway, going back to CML. So since the 1970s, we know that the hallmark of this disease is a chromosome called Philadelphia chromosome. What is that? So the way you diagnose this disease, you do a bone marrow biopsy, right? When you do the bone marrow, you look at the 23 chromosome pairs we have in our body, okay? And you will find this distinct chromosome called Philadelphia chromosome, because this was discovered in Philadelphia. And it's a distinctly looking chromosome. That chromosome is the result of a translocation between a portion of chromosome 9 and a portion of chromosome 22. All right, so part of chromosome 9 is spliced off, part of chromosome 22 is spliced off, and they join together. So since the 1970s, we all know that if you find that Philadelphia chromosome in a bone marrow biopsy, that's CML. We did not know why that was. But we know that Philadelphia chromosome is the main problem, the main culprit in the development of CML. Okay? Because normal people don't have Philadelphia chromosome. All CML patients have the Philadelphia. So we know that. But we don't know what it means. We don't know what it does. Through the years, through research, we were able to discover that the molecular basis for why the Philadelphia chromosome causes CML. See, that translocation of 9 and 22 causes a part of what we call a promoter area in one chromosome to attach to another portion of the other chromosome that causes that chromosome to produce white cells. Okay? And we were able to isolate the molecule that causes the molecule that is produced as a result of that fusion, the molecule that's the culprit for causing the development of CML. So that molecule is called BCR-ABL. Okay, I know I'm getting technical, but just bear with me. So BCR, breakpoint cluster region, is that breakpoint that I was telling you about. ABL is the oncogene that is stimulated by the BCR. And what happens is a series of reactions that causes the body to make white cells. That was the key in this disease. Now, after discovering that fusion gene, the BCR-ABL, it was just a matter of time for them to discover the biochemical reactions that result in the production of the white cells. Now, whenever you have biochemical reactions, you have enzymes, what we call rate-limiting enzymes. That's the critical step in causing the reaction to proceed. Without that enzyme, that reaction will not proceed. So the next thing that happened was they identified that critical enzyme. That critical enzyme is called tyrosine kinase. All right, TK. That's very important because once they discovered that the tyrosine kinase enzyme was the critical enzyme for the process to proceed, it was a matter of time before they found they basically synthesized a drug to inhibit that enzyme. And that was the key. That drug is called Gleevec, which is available in the Philippines. All right? So Gleevec is what we call a TKI, tyrosine kinase inhibitor. All right? It inhibits the critical enzyme that allows the malignant process to proceed. How effective it is it? We were all floored when that drug came out because this is a pill. Before Gleevec came about, you treat chronic myeloid leukemia with bone marrow transplant. That is the only curative option. Now, when you do a bone marrow transplant on a CML patient, this is an allogeneic transplant, meaning to say you have to get somebody else's bone marrow, kill all the bone marrow in the patient, infuse a foreign bone marrow, because this is foreign to the patient, and then you have to immunosuppress the patient so that the bone marrow does not get rejected. And at that time, when we were doing bone marrow, allogeneic bone marrows for CML, the treatment-related mortality alone, meaning to say your chance of dying from the procedure, not from the disease, just the procedure alone, is 25%. 25%. Treatment-related death. Okay, you have a 25% chance of dying from the transplant, not the disease. Because these people are very sick, because if they're immunosuppressed, they have absolutely no immune system. All right? One of my classmates from medical school actually died from a treatment-related infection of her transplant. She had CML. All right? The tragedy is, the Gleevec drug came out like 3 months after she died. Okay, so what happens when you give somebody Gleevec? It's a once-a-day pill. Okay? Very magically, the white cells start to normalize, like within a week, 2 weeks. From 100,000, it's gonna go down to like 10,000. But that's not the end of it. Remember the BCR-ABL molecule I mentioned earlier? We can actually measure that in the lab now. And we can look at what we call molecular remission. Not just, oh, the blood count is normal, you're free. No, we go even deeper than that. Because that BCR-ABL fusion gene disappears. Okay? So we look at what we call complete molecular remission, not just cytogenetic remission, because that Philadelphia chromosome also disappears with Gleevec, by the way. Okay? So it's not just cytogenetic remission, it's not just blood count remission, or talking on the molecular level. So Gleevec can cause the BCR-ABL to go to 0. I have a lot of patients whose BCR-ABL assays are 0. Okay? Years since they were diagnosed. But then it goes even further, because the question arose whether, okay, so I have a patient who's BCR-ABL free or 0 for like 5 years. What if we stop the Gleevec? We're talking about a malignant condition in here, okay? So about 2 years ago, they did a study looking at patients who have been in complete molecular remission, meaning BCR 0, for at least 2 years. They divided the group into two groups. They divided the patient into 2 groups. One continues the Gleevec once a day with basically no side effect, okay? Because this is not chemotherapy. Your hair does not fall off, you don't go nausea, but none of those. This is a very benign pill. Basically nothing. All right, so one group continues the Gleevec, the other group stopped the Gleevec. What was the result? 50% of those who stopped the Gleevec remained in complete remission without any medication. Their BCR-ABL remained at 0. Half of those, okay? Now, the other 50% whose BCR-ABL started going up again, when they got reintroduced to Gleevec, their BCR-ABL went down to 0 again. So, CML is an example of a malignant condition, a leukemia, that can actually potentially be cured. And it all boils down to identifying what the heck is going on the molecular level, on the genetic level, finding a drug against what's the critical step. So I gave that as an example because it's one of the success stories in oncology. Of course, it's still a big challenge out there, okay? But for the most part, most blood disorders, a lot of them are curable now. There's another type of leukemia called APL, acute promyelocytic leukemia. Now this is the bad leukemia. Remember when I said acute? It's aggressive. So now we also, they were able to map out the same thing, the molecular base for this disease. And they came out with 2 pills, not chemotherapy again. Patra, or trans-retinoic acid, which is basically vitamin A, and arsenic trioxide. We don't do chemotherapy for APL anymore. What is the cure rate? I'm talking cure, probably 90%. Okay, so great examples. Now, yeah, but you're like, okay, well, yeah, those are great home runs, but what about the more common tumors we deal with? Lung, breast, colon, prostate, pancreatic. What is going on in this field? Well, we are slowly making progress in the solid tumor fields as well. These are hematology, what we call liquid tumors, leukemia, lymphoma. But we are beginning to make some inroads in in the solid tumors as well. So what we're trying to do again is identify what we call mutational targets. Okay, so I'm gonna start talking about some of the more common tumors. So let's start with the most common tumor, the most #1 tumor, both here and in the US, and that's lung cancer. Okay, so lung cancer is easily approached by thinking of lung cancer as two types, two general types: small cell, non-small cell. All right. So small cell lung cancer, 100% linked with smoking. Nobody develops small cell lung cancer that does not smoke. Okay? That's what causes that type of cancer. And you differentiate them into two groups because they behave differently and they're treated differently. So small cell lung cancer is a very fast, aggressive type of lung cancer. It's almost like an infection. You develop lung cancer, the chances of having, thank you, metastatic disease at the time of diagnosis is about 60% because it spreads fast. So by virtue of that, small cell lung cancer is not a surgical disease. It's pointless to do surgery because by the time you take out the tumor in the lung, that would have spread somewhere else. Okay? So it's very fast dividing, but by the same token, cells that divide quickly are the most amenable to chemotherapy. Remember that. Okay? So if you have fast dividing cancer cells, they're the type of cells that chemotherapy is most effective on. Okay? Because chemotherapy acts on fast dividing cells, which is why people lose their hair. Because hair follicles divide quickly. So any fast dividing cells are the cells that are affected by chemotherapy the most. All right? So small cell lung cancer is easily treated with chemotherapy. I mean, they melt. Okay? Here's the problem. Chemotherapy, they recur. Basically, when they recur, the chemotherapy you used in the beginning will no longer be effective. So that's why it's a fatal disease. Initially, yeah, you get great results and patients happy and everything, but they almost invariably recur. And then you won't have anything to treat them with. There's also some active research in small cell lung cancer, and it looks very promising. That actually it's been approved. It's still treated with chemotherapy because of the fast dividing nature of the cells, but immunotherapy is now making its way into small cell. And I'll talk about what immunotherapy is in a while. The non-small cell variety is the more common type. That's the adenocarcinoma, bronchoalveolar, etc., etc., etc. So about 1/3 of all lung cancer patients are small cell. 25% are small. 75% are the non-small cell variety. Okay? Now, when here's the big breakthrough in non-small cell. So we now have identified mutations. Okay, what are mutations? So mutations are genetic abnormalities that you only find in the cancer cell. And these mutations are what drive the cancer cells to grow. See, now this is why I'm talking targeted therapy now. You target this mutation. So instead of giving somebody chemotherapy, which I compare to a bomb, okay? Because yeah, you lob a grenade into your enemies and your troops that are fighting each other. Yeah, you kill your enemies, but you also kill your friends. So it's it's a bomb. That's what chemotherapy is. Targeted therapy is like you only identify your enemies and you just shoot the enemy. You have no collateral damage. Okay? So that's what we do when we look for the mutations. Okay, so there are right now four important mutations that is tested in every biopsy of lung cancer in the US. All right, and I want you to remember because this is important. So the most common is the mutation called EGFR, epidermal growth factor receptor. Okay, that's one. Second is ALK, anaplastic lymphoma kinase. Third is PDL1, that's the immunotherapy thing. And another one is ROS1, okay? So let's go through each and every one of them. I want to discuss EGFR first, because that's very important, especially in this country. So, EGFR mutations are actually interesting because they are prevalent in a certain type of patient. What is that patient? It's a woman who never smoked and is Asian. Okay? That is the most common, not that it doesn't happen in males who smoke, but it's prevalent among women with that type of characteristic. Asian non-smoking female. Alright? Why is EGFR important? Because we have a specific drug for EGFR positive patients. I'm not gonna quote names, but you know who I'm talking about. There's a former senator of this country. I think that's what, I don't know her history, but I think that's what she had. Now, back when she was still around, she received an anti-EGFR drug called Tarceva. Effective drug, good drug. Again, no side effects. The most common side effect of an anti-EGFR drug are pimples. That's it. No hair loss, no low blood counts, no nausea, no vomiting, pimples. And by the way, if you develop the pimples, the acne, that means the drug is effective. The more acne you get, the more effective the drug is. Okay. But there has been an advance in that field. So Tarceva was the standard drug. About 2 years ago, another drug, which I know is available here, came out. It's a drug called Tagrisso, or osimertinib. Tagrisso made Tarceva obsolete. Because in a head-to-head comparison study between the two drugs, not only was Tagrisso way more superior, and by the way, this drug, this pill, goes into the brain. So, yes, so if your tumor spread to the brain, that tumor will be treated by this drug. That's how good the drug is. All right? Tagrisso not only beat Tarceva in terms of efficacy, hands down, but in terms of side effect profile, it also won. That's why in the US, Genentech, which makes Tarceva, does not market it anymore. They gave up. Talo-talo sila nitong isang drug eh. I know that drug is available here because 2 years ago, I forgot the name of that Philippine Medical Oncology Society, whatever. They asked me to give a talk. And that was the day Tagrisso was being launched in the Philippines. So that drug is available here. It's a once-a-day pill too. I mean, unbelievable results. I have two patients in the US, both Filipinas, okay? Their cancers are gone. How long, I mean, I'm not saying it's a cure, but one had like tumors all over the lung, like within 2 months, repeat PET scan, wala, gone. On a pill, once a day. And she was very happy because she's like, so now doc, can I go back to the Philippines for vacation? Absolutely. Just make sure you bring your pills with you. Now, if she were getting chemo, no, she cannot go back to the Philippines because she has to continue her chemo in the US. Not to mention, I have to monitor her for side effects. This is just a pill. Okay, have a nice time. Okay? So EGFR, remember that. And remember about the woman, non-smoking Asian. Okay? So ALK, A-L-K, it's actually anaplastic lymphoma kinase. So you're like, okay, what is a lymphoma drug doing in cancer? Well, it was serendipitously discovered. So this drug was, it's a pill also, by the way. This tablet was supposed to be developed for a type of lymphoma called anaplastic lymphoma. But when they were doing cell culture studies, they found it was also effective in a type of lung cancer that harbors this ALK mutation. So, same thing. You test the patient for the ALK mutation. If it's positive, you do not give them chemotherapy. You give them a pill. Same thing, except that this is a different type of pill. This is not the Griso. You give them a pill called Alecensa. Okay? Before, there was another pill, kind of like Tarceva, that has also become obsolete because this new drug Alecensa is also way more effective and also less toxic than the original pill. Okay? Salcori. Alecensa, also here's the other good thing. Same thing, it goes to the brain. These ALK-positive lung cancer patients actually who have brain metastases, some of them actually do not need radiation to the brain anymore, which is a big, big thing. Because when you radiate the brain, you destroy brain cells, that patient's IQ goes down. So if you can avoid cranial radiation as much as possible, that's always a good thing. Now you can. I mean, it's still standard therapy right now to radiate brain mets. But I know in the near future, maybe within this year, because the studies are being done, they will publish that study, which will show you don't need brain radiation anymore, and brain radiation will not be standard therapy for ALK-positive lung cancer patients. Again, I have a patient in the US, Filipino naman. He's young, 37 years old, playing basketball. He goes, why can't I breathe? So he ended up in the hospital. Half of his lungs were filled with water, with fluid. They drained the fluid, they found cancer cells floating in the fluid, okay? Lung cancer, adenocarcinoma. So, what was the first thing I did? I tested it for the mutations. He's ALK positive. Gave him Alecensa, is doing very well to this day. Just saw him before I left. Another patient, Filipina rin. Ganon, so Filipina, non-smoker woman, Asian. I thought, oh, this is gonna be an EGFR positive patient. No, she had a mass here. Biopsy, consistent with lung primary. Mutation, she is ALK positive, not EGFR, I was wrong. So, you know, I thought Filipina, non-smoker. Same thing, gave her the Alecensa, that was 3 years ago. None, gone. On a pill. So these are improvements. Now, the third one I was telling you about is PDL1, Program Death Ligand 1. Ito na yung immunotherapy. Okay? So what exactly is immunotherapy? So immunotherapy, what really kills the cancer cells in our body is our immune system. Specifically, the T cells. So, at any point, at any time, everyone in this room has some form of cancer going on in their system. Okay? You have some form of cancer cells floating around. Why don't you develop fulminant cancer? Because of your immune system. Which is why the people who develop cancers are usually the elderly, because their immune system is weak. Our immune system makes sure that all these malignant, independently dividing cells are kept in control. Okay? So, immunotherapy basically is revving up the immune system to kill the cancer cells. That's all it is. And the good thing about that is because since one of the most common pathways in the development of cancer is a weakened immune system, immunotherapy is effective in a lot of cancers, right? Because that's one of the basic steps in the etiology of cancers. So, immunotherapy is not just effective in lung, it's effective in now about 20 types, all right? It was first discovered or studied in melanoma, which makes sense because melanoma is very much dependent on the immune system. Chemotherapy is ineffective in melanoma, so an immunomodulating drug, let's try it in an immune-related cancer. Oh my God, it worked. This was 2011 when it first came out. Then they postulated since, let's try it in other cancer types. So now from melanoma, one cancer is now approved in about 20 different, including lymphomas, okay, blood tumors. So what you do in lung cancer then, the third one, so EGFR, PD1, PDL1, you look at the PDL1 assay of the tumor. A positive PD1, PDL1 is anything more than 1%. Okay? But here's the thing. If the patient's tumor's PD1, PDL1 assay is more than 50%, meaning to say it's strongly PDL1 positive, you do not give them chemotherapy, you just give them the immunotherapy drug. Okay, so then you spare that patient the horrors of chemotherapy. If the PDL1 is between 1 and 49, then you have the option of adding the chemotherapy with the immunotherapy. But if the PDL1 is more than 50%, you can use single agent immunotherapy. How effective is it? It's very effective. These patients, it's not a cure, again, by all means, but these patients' tumors regress, and then they just stay like that. Some of them go into complete remission, means the tumors all disappear. And you just keep maintaining them on the drug. The problem is, we don't know how long to give it, because we have not done the studies yet to see if you can take them off the medicine. And of course, the rational thing to do is just keep giving them the medicine, because you don't know if you stop whether the tumor will flare up or not. Now, unlike chemotherapy, which it's nuclear, it destroys everything, immunotherapy takes a while. Because remember what I said, it revs up the immune system, and then the immune system destroys the cancer. Chemotherapy directly destroys the cancer cells and everything else around it. Okay? So when you give somebody immunotherapy, and this is what I've been trying to teach my fellows, do not do a scan like a month later. Because if you do a scan, and the tumor, then you're, oh, it's ineffective. And by the way, there's this thing called pseudo-progression, which happens in immunotherapy. Because what happens is, if you give somebody immunotherapy, it revs up the immune system. The immune system then attacks the lesions that you see on the scan. And if you do a scan, it looks like it's worse, because there's all sorts of immune processes going on around the tumor. That's what we call pseudo-progression. And the mistake a lot of doctors make is, kasi sanay sila na, oh, you do a scan in chemotherapy after 2-3 cycles, and then they do the scan and they're like, oh my God, it's gotten worse. No, it's actually getting better. So they'll say, oh, you failed that drug. Stop the drug. No, you do not do a scan, never less than 3 months. The further away from the start you do the scan, the better off you are. Because if you do a scan in 2 months and it looks worse, keep that immunotherapy going, do another scan in 3 months, and you'll see it's gonna be much better. That's what we call pseudo-progression. Okay? So tell your doctors about that. I'm sure they know about that. But I'm just saying, that's a common mistake. Alright? Don't let them just take you off immunotherapy because your scan looks worse. You gotta give it time. Alright? Alright, so that's lung cancer. Breast cancer. Okay. I've said this before in this room. It's not enough to just say, you have breast cancer. No. There are 4 different types. You have to clarify what type of breast cancer you have. For the purposes of this group, I will just say there are 3 types. Okay? The 4 types are luminal A, luminal B, which you can actually sort of group into one. HER2 positive and triple negative. Okay, what am I talking about? So whenever you do a biopsy of a breast mass that turns out to be invasive, okay, iba yung intraductal ha. Okay, let me clarify what I mean right now para hindi tayo malito. Breast cancers usually start in the ducts, you know, where breast milk passes. So this is a duct, okay? When you say intraductal or ductal carcinoma in situ, they mean the same thing. That means because the cancer will always start from the innermost part of the duct and they grow out and spread. Intraductal or ductal carcinoma in situ, DCIS, the tumor is confined within the duct, within duct. Okay? That's the earliest form of breast cancer. You do the surgery, sometimes you radiate, you're done. Very curable. Alright? Invasive or infiltrating ductal carcinoma is the one that has penetrated the duct. That's the type that spreads around. Okay? So for the purposes of this discussion, I will refer, when I say breast cancer, I'm talking invasive. Forget the intraductal because that's magaling gumatin. So, there are 4 types. So luminal A and luminal B can be grouped together, triple negative and HER2 positive. So when you do a biopsy, at least in the US, there are always 3 things that we look for. ER, or estrogen receptor, PR, or progesterone receptor, and HER2 new. Okay? So, estrogen receptors are normally occurring receptors on the surface of the cell. If you look at the normal breast tissue, on the surfaces of the cell are receptors for the female hormone, estrogen, and progesterone. So we say ER, PR, those are receptors for estrogen and progesterone. That's normal. So the estrogen attaches to the receptor, the progesterone attaches to the receptor, and it causes growth of the cell. Okay? So you will have tumor cells. Majority of tumor cells are going to be ER/PR positive. Which is why if your biopsy says positive ER, positive PR, that's a very good thing. Okay? Ang masama is when your tumor does not look like the original cell. Because this guy is really a rebel. This means it will do whatever it wants. If your tumor cell sort of looks like the parent normal cell, that's a good thing. So ER/PR is found in normal cells. If your tumor is ER/PR positive, that's very good. The higher the ER/PR level, the better off you are. All right? So we do ER/PR, then HER2 new. What the heck is HER2 new? Okay. So HER2 new is actually a gene. So it's in the DNA of the tumor. HER2 new produces a protein called HER2 new. About a third of patients with breast cancer will be HER2 positive. If your tumor is HER2 new positive, it's an aggressive tumor because that protein HER2 new causes growth of the cancer cell totally independent of the ER/PR pathway. Okay? So HER2 positive, bad. ER/PR positive, good. Alright? So we look at those 3 things. Now, about 20 years ago, if you're HER2 positive, you have the worst type of cancer because it's aggressive. Talaga mabilis kumalat yun. So what happened 20 years ago? Well, 20 years ago, they identified that mutation, HER2 new. And like I said, it was just a matter of time before they produced an antibody against the target. What is our target? HER2 new, the protein. What is that drug called? Herceptin. Trastuzumab. The guy who developed that drug, Dennis Lehman, somebody I know. I've met him. Putting that aside. So HER2 new, Herceptin revolutionized the treatment for HER2 new. Because then they did studies. By itself, HER2 new is not as effective. But if you combine HER2 new with chemotherapy, especially a taxane like Taxotere, Taxol, unbelievable results. Okay? So, if the patient tumor is HER2 positive, we have a good drug. So now, if you're HER2 positive, diagnosed, all of a sudden yung oncologist tuwa. Because I know I can treat your disease. It's not as aggressive anymore. And then to make it even better, about 6 years ago or so, there you go, very good. So they came out with a second generation HER2 drug called Perjeta, okay, or pertuzumab. Whenever you see the letters AB or IB at the end, like pertuzumab, that AB stands for antibody. So these are antibody drugs against a target antigen or protein that the tumor makes. Okay? So, Perjeta came out. So then they said, why don't we combine? So we know that Herceptin and, let's say, Taxotere produces spectacular results. What if we combine the second generation HER2 new for Jetta? So about 4 years ago, they came out with what we call the Cleopatra studies. We are fond of putting names on our clinical trials. So this is called the Cleopatra study. Okay, so what is the study? Of course, these are for all metastatic HER2 positive patients only. All right, that's our target population. Same thing, you divide them in 2 groups. One gets the standard of care, which at that time was the dual treatment of Herceptin and chemo. That's standard, because that's what we do in oncology. You have a standard treatment, you have an experimental treatment, you divide the population in 2, and then you do statistical analysis, and let's see how good or better or inferior the new ones compared to the standard. Standard dual therapy, experimental triple therapy for Jetta, Herceptin, Taxotere. What was the result? Unbelievable. The experimental arm, the overall survival is 16 months. That's unheard of in oncology. Normally, in oncology, if you do a similar, what we call phase 3 trial, and let's say the new drug produces an overall survival of 3 more months, automatic FDA approval yun. But 16 months, a year and a half, that's unheard of. So, some of those patients in that original study, which 5 years ago, are still tumor-free to this day on the triple regimen. But the triple regimen, they give the chemotherapy only for 6 months. And then they maintain them on the 2 anti-HER2 drug for, I don't know, the rest of their life. We don't know how long yet. But my point is, 5 years after they did the treatment, some of them are still cancer-free. I think about 20%. So, another example of what we call targeted therapy. Now, I mentioned triple negative. What do I mean by that? Well, that means they're negative for all 3. They're ER negative, PR negative, HER2 negative. That is the worst type of breast cancer now. Why? Because we don't have anything to treat it with, not yet. We are beginning to make inroads though. It's a disease that's also aggressive, okay? For whatever. Remember what I said, the cell does not look like the original cell, when you say it does not have the ERPR, okay? Even the HER2, you don't worry about it, but these are also fast-growing cells. Not as fast as the HER2, but the problem is we don't have anything to treat them with. Until recently, so about a year ago, they did a study looking at combining a drug called Abraxane, which is basically a taxane, like Taxol, Taxotere, combined it with an immunotherapy drug called Tecentriq or atezolizumab, which I know is also available here. And so the study design was, because the only thing we had for triple negative is chemotherapy, which is not very effective, okay? So chemotherapy, which is usually a platinum-based regimen, chemotherapy versus Abraxane Tecentriq, panalo to. So now, the standard of care in the US for metastatic triple-negative breast cancer is a combination of an immunotherapy, Tecentriq, and a taxane, Abraxane. Okay? Spectacular results. I have a patient, young Filipina lady. She is only 47 years old. That is the absolute worst. Premenopausal triple-negative. She was diagnosed when the tumor was still localized. Okay? So I gave her chemotherapy, followed by surgery, followed by radiation. Within 6 months, the tumor came back. Okay? It came back in her bone and near the lymph node, the axilla near where the tumor was. So I gave her the Tecentriq and the Abraxane. After, because you give the chemotherapy for, same thing, you give the chemotherapy for 6 cycles, that's every 3 weeks. And then you stop the chemo and then you maintain them on the immunotherapy because, it's the effective and less toxic part. So of course, after 3 cycles, I do a scan. See ano na nangyayari sa tumor. She had lung lesions pala. The lung lesions disappeared. Okay? only a little bit of the bone lesions were left. Okay, so she completed the 6 cycles. I do another PET scan. Gone.
Wow.
She's here in the Philippines right now, vacationing. Sabi niya, Dok, magbabakasyon ka rin lang eh. Magbabakasyon na rin ako. Total, wala ka na sa face. I don't know where she is there, but she's somewhere here. When I come back, she comes back, we resume that to center. Okay? So, and then just this morning, right before I came in, Stanford is coming up with a very promising experimental treatment also in triple negatives. The term they use is electroporation. It's a very complicated method, but what they basically do is they have plasmids. They're like small cellular components. What they do is they incorporate a substance called interleukin-2, which is part of the immune system, within the plasmid. They directly inject it into the tumor. And according to their preliminary study, these tumors all disappear today. So that's promising. That's press news just this morning. All right, so that's breast cancer.